A very good evening to all of you. On behalf of PG Examination Forum, I welcome you all to the our second session of Visual Fields A to Z. This will be covering the interpretation of single field analysis printout and progression analysis. A few words about the PG Examination Forum. The PG Examination Forum, this is a WhatsApp group, which is a family of nearly 2,500 plus students, which are where we include junior residents, senior residents, as well as fellows in ophthalmology. And this is not only a forward group, but it is an academic discussion group. And this group has helped students during their studies, thesis submission, and as well as exploring their future options. So to join PG Examination Forum, you need to message your name as well as your college name to Dr. Deepak Mishra, sir, on the number mentioned below. So moving on to today's session. Today's session will be chaired by Dr. Tanuj Radha, sir. He's a professor of ophthalmology at RP Center for Ophthalmic Sciences, AIIMS, New Delhi. Sir has nearly 300 even more research publications under his name in peer-reviewed index journals. He had authored 5 textbooks on glaucoma. He's the Secretary General of International Society of Glaucoma Surgery. He's the director of Asia Pacific Glaucoma Society, also the chief editor of Journal of Current Glaucoma Practices and associate editor for Journal of Glaucoma. And he's also the senior chair of Associate Advisory Board for the World Glaucoma Association. For our today's speaker, we have Dr. G.R. Reddy, sir, who is the director of G.R. Reddy Eye Care Center in Andhra Pradesh. He has completed his MS Ophthalmology from PGI Chandigarh, and he's the author of a Practical Guide to Interpret Visual Field. I welcome both Dr. Tanuj Radha, sir, and Dr. G.R. Reddy, sir. The moderators for today's session includes Dr. Deepak Mishra, sir, who is a faculty at RIO BHU Varanasi, and he's the founder as well as the admin of the PG Examination Forum. He's also the chairman of Scientific Committee, UPSOS, and he's the national convener of SSTC. And our second moderator is Dr. Sstc Mathur, sir. He's the chairman of Scientific Committee, ACOIN, and the national convener at SSTC. He's also the secretary of NZOS and UKSOS. Sir owns a high-tech eye institute and laser center in Kashipur, Uttarakhand. I welcome both of you. Dr. Deepak Mishra, sir, will be joining us later, and the session will be moderated initially by Sstc Mathur, sir. And the special invitees for today include Dr. Pradeep Chandni from Gujarat, myself, Dr. Shubhangi from Raipur, Dr. Pragati Tiwari from AIIMS Patna, Dr. Upasna Ajmani from RIO Amritsar, Dr. Pankti R. Shah from Ahmedabad, Dr. Vibha Singh from Hindu Rao Hospital, Delhi, and Dr. Rushal Bansali from Surat. So now I will like to hand over to Dr. Mathur, sir, for the further.
Thank you, Shubhangi, for the nice introduction follow us. As you all know, this PG forum has been made on the benefits of the PG for their education, for their guidance, for joining the fellowship, and how to get the pass exam in the DNB examinations. We are trying our best with the help of faculties. We have more than 300 faculties who are helping us in guiding the post PG. But today's session is a second part of this. First, we have already covered about the basics of the visual fields. And today is about the interpretation of visual field. Dr. Reddy sir is remarkable. We appreciate him. He's a first in teaching the students. And I hope all of you, not the PGs and the persons who are doing practice, they are joining us, will be benefited by his talk. And we have Tanuj Dada. We all know him. If we have in the glaucoma, if you have in any interest in glaucoma, you should follow him. And you will get at least something from him. He is the author of the books. He has the peer-reviewed journals. He talks on glaucoma in each and every conference. And we have learned a lot from him about the glaucoma. Though I am not a glaucoma specialist. So, Dr. Tanuj, I request you to address the PGs and guide them for the future, their future, and wish them good luck for the future. Thank you, Tanuj.
Thank you, Dr. Sstc. I really congratulate you on this effort you have done for PG education in the country. It is a very good effort and it will be very helpful for all the postgraduates. And regarding the basics of glaucoma, I think whenever a PG student joins ophthalmology, you have to learn basically 3 important things. That is examination of the optic nerve to detect glaucoma and evaluation of the anterior chamber angle to tell whether it's an open angle glaucoma or angle glaucoma. And then the critical part comes the evaluation of the visual field. Now glaucoma, you have 2 components. You have structural changes in the optic nerve and then you have functional changes. So the functional changes are picked up by the visual field. So it is very critical to understand how to do visual fields and how to interpret the visual fields. Now, there are a lot of changes, recent advances occurring in perimetry. So I'll just explain in a few words what are the recent advances. So we have been following central 30-degree perimetry for glaucoma, what we use central 30-2. And now either we use the 30-degree test or the 24-2 test for most of our glaucoma patients. And that is come by the name of Sstc standard, Swedish Interactive Threshold Algorithm Standard. Now, in the recent years, two changes have occurred. Sstc standard 24-2, you have Sstc fast strategy, which has decreased the test time. In the third strategy that has recently been released is called Sstc faster. So that is 30% faster than Sstc fast and 50% faster than Sstc standard. So you have Sstc standard, then you have Sstc fast, and now you have Sstc faster. So that is the additional strategy that is now going to become the gold standard because the testing time has been reduced to less than 4 minutes, and that is very good for glaucoma patients. The second advancement in perimetry has been that a number of patients, it was found that the macular ganglion cells are being affected in glaucoma before the retinal nerve fiber layer. So to test that, you need the central 10-degree testing. Now it is very difficult for the practitioners to do a 10-degree field and then a 24-2 or a 30-degree field. So what has been done is you have now 24-program in which they have incorporated 10 additional points. So this is 24-2 Sstc faster C. So 10 additional central points have been incorporated to pick up the early defects in the ganglion cells in the macula. So that will identify nearly all glaucoma patients. And so these are the two new strategies for glaucoma. And for doing the perimetry, there are two important things you must understand. Never start therapy based on the first visual field printout because there's a learning curve in perimetry. So unless you get two stable visual fields in which there is no change, don't diagnose the patient as glaucoma on the first visual field. Always repeat the visual field. The current recommendation is to do at least 3 visual fields in the first 2 years. That is because you get an idea of what is the velocity of progression, how fast the patient is progressing. So now I'll stop here. So, you know, Dr. Reddy, he is the stalwart in visual fields. And I remember when I went to All India Ophthalmic Society meeting, there used to be one hall where there was no place to sit. It is overflowing. So that was the hall in which Dr. Reddy was doing the visual field. So I attended his course in AIOS long time back. And in my whole life, I have never seen better teaching and better understanding of the visual field. So all of you must get his basic book on visual fields and go through that and attend his lecture and then revisit this video and you will learn about the art and science of perimetry. So without much delay now, I would request Dr. G.R. Reddy to start his lecture on perimetry. Thank you. Dr. Reddy, you can share your slides. Okay.
Thank you, Professor Tanudhara sir, for your kind words. Now, today, I will be talking about the interpretation of visual fields and indications when to repeat the test 10-2 pattern and progression analysis. As you know, in our clinical practice, the glaucoma patients can present with the printout
with a glaucoma suspect or early glaucoma, the printout of established case of glaucoma, or the printout cataract associated with glaucoma. The main aim of interpretation of single film analysis printout in a suspected case is to diagnose glaucoma. In established case of glaucoma, the interpretation is to set the target IOP. The target IOP, to decide, we have to know the location of the field defect, the extent of the field defect, the depth of the field defect, the direction of progression, and the foveal status. All these things we have to assess and set the target IOP to arrest progression, whether it is vertical progression, horizontal progression, or onset of new field defects. In the case of cataract associated glaucoma, the fields will help us when to do trabeculectomy alone, when to do cataract alone, or when to do combined procedures. So we have to analyze the field defects, the glaucoma field defects. The analysis of the glaucoma field defects can be divided into a quantitative analysis, which tells the location, extent, and direction of progression. And qualitative analysis, the raw data, global indices, and GHT, to tell the depth, the foveal status, and direction of progression, and which will help us finally for the diagnosis and to set the target IOP. As you know, the open-angle glaucomas are classified into primary open-angle glaucoma and normal tension glaucoma on the basis of. Since the location of the field defect, glaucomatous field defect, exactly where the field defect is starting, plays a major role in the management and prognosis of glaucoma. The glaucomas can be classified into type 1, where the glaucoma starting outside 10 degrees, type 2, glaucoma starting within 10 degrees, and glaucoma starting both outside and within 10 degrees simultaneously. And there can be divided into two subsides, the field defect traveling towards the fixation or field defect progressing away from fixation. As you know, basically glaucoma is the loss of ganglion cell, which will be reflected in the optic nerve head. And mostly, since most of the fibers enter, as you know, the ISNT rule, the more fibers enters into the inferior pole than the superior pole. The superior pole is more than the nasal pole, nasal side, and the nasal side is more than the temporal side, following the ISNT rule. When there is a loss of retinal ganglion cell, the vertical diameter will increase, the notch may appear, there may be wearing of the blood vessel, there may be a Baynard sign, there may be hemorrhage, be associated with the loss of beta zone. But all these signs, when the disc is very small, these signs may appear late, and if the disc is large, to appreciate these signs, it may be very difficult. So when a field defect is seen, it has to fulfill certain criteria, what we say the Anderson's criteria, to be labeled as glaucoma. The field defect should be minimum 3 points. 1 point will have a p-value less than 1%, and 2 points will have p-value less than 0.5%. And they should be in the pathway of the retinal fiber layer, and these points should be the non-edge points of 30-2. In a localized scotoma, we can consider total deviation probability plot. When there is a generalized depression, you consider the pattern deviation probability. And the PSD should be less than 5%, and glaucoma field test should be outside normal limits. Any field defect to be labeled as glaucomatous must fulfill the minimum 3 criteria. Now, I will be talking about nearly 16 cases, how to interpret visual cases. Out of these 5 cases, 6 cases. All these 5 patients are known patients of glaucoma, this under my care for the last 5 years. And this is actually glaucoma suspect case. And if you see, there is no clue from the fundus. There is no clue from the fundus to label as glaucomatous disc. And all these cases, they started beyond 15 degrees on the periphery. The first case, this case with a strong family history, glaucoma, and the IOP is around 20s, came with the printout with labeled as under glaucoma medication presented 24-2 SETA standard, and reliability factors are excellent. If you see 0, 0, 0, almost 0, 0, 0, excellent. And this is the non-edge point, because in 30-2 we don't consider edge points. This is the 24-2, the edge points, and you see the fulfilling Anderson's criteria, 3 points, and PSD is and JHT are fulfilling the Anderson's criteria. So this patient diagnosed as glaucoma because of strong family history. But whenever you see edge scotoma, you always see what is this value. If you see the absolute scotoma, any edge scotomas are absolute scotomas, and you see the next point, which is right here, then it should not, I think of an artifact. It can be a rim artifact, or a small pupil, or false negatives. All these 3 can produce artifacts. And when the test is repeated, the scotomas disappear again, 24-period, and the fixation loss is well done field, well done both eyes, and the OCT is also normal. So at this patient, you can tell to the patient is a glaucoma suspect. At this stage, you are not having glaucoma, but he must be kept under observation because he is a strong family history. The second case, there is a cup disparity. The tensions are IOP. Whenever say IOP 20, it's all corrected IOP. And when you are suspecting glaucoma on the basis of the disparity of the cups of the both eyes, hold the printouts, the left eye, right eye printout with the right hand and the left eye printout with the left hand, and interpret the visual field simultaneously as in neurological cases. And if you see this, the nasal step, here the nasal step, and here a scotoma on the temporal side and then the nasal side. This is the corresponding point. This is the temporal scotoma. This is the temporal scotoma. This is the point, the temporal, and this is the point, temporal. So simultaneously, so simultaneously,
I request everyone else to please mute their mics.
whenever we are suspecting glaucoma on the basis of disparity between the 2 eyes, always hold the printouts, the right eye printout with the right hand and the left eye printout with the left hand. And this is the nasal step, and here is the nasal step. This is the scotoma on the nasal side. This is the scotoma on the nasal side, and this scotoma on the temporal side. This is the scotoma on the central. So simultaneously, we are seeing the same locations in the same place, and something is going symmetrically. And this is an important clue to diagnose glaucoma, and this patient is maintaining the reproducible field effects under my care for last 5 years. This is the third case. There is no clue from the fundus except the disparity. Suspected something may be there. And when we took the field, 24-2 SETA standard, well done field, with the PSD, no sign in front of it, and 3.44 dB with a p-value less than 1%, JHT outside normal limits, and they are the field effect is fulfilling the Anderson's criteria. And you see this is not an absolute scotoma, and labeled as glaucoma, and started the treatment. and it is after repeatable and repeated the test, it is reproducible. Always a field effect should be reproducible. As Tanuj Dada already told, minimum you must have minimum 2-3 fields must be there whenever you should diagnose, when you try to diagnose glaucoma. And after 1 year, it is reproducible field, and OCT is also showing corresponding thinning of the nerve fiber layer. So whenever now this patient, the fourth case, this patient, there is no clue from the fundus. If at all, almost the rim is very healthy, uniform. You see the rim, except for the large disc, and there is no clue from the fundus. And this patient came with a advanced glaucoma labeled from OCT, and the fields were not done. And if you see the rim marking by OCT is by identifying the Brooks membrane opening and interlimb membrane opening margin, and the Brooks membrane opening with the minimum rim width from the distance between the Brooks membrane ring marking and the interlimb membrane circle, the minimum distance is calculated and gives the rim area. If you see the rim area is not properly marked, almost there is no rim. So there is an algorithm failure. Even if you see the retinal nerve fiber layer tomogram, the segmentation is not proper. Even though signal strength is good, 8/10, still the field you cannot take it for granted. When the field is done, and the field is 1/16, the false positives are 14% and false negatives are 5%. As you know, the false positives you can take up to 15% and false negatives are 5%. So if the false positives are on higher side, even this, so normally the scotomas may be lesser. So if these scotomas we can take it for granted there, and it is reproducible 3-4 times. If you see the localized scotoma started in the lower nasal quadrant and progressing upwards. When it is converted to pattern plot, almost they are now disappearing. The superficial scotomas, they disappear in pattern plot. It means it is a progressing field defect. And this left eye is also showing the upper nasal field. Recently must be because by adding 1 dB, it disappeared. That means very recent onset of scotoma in the left eye. And early glaucoma, the unfortunate that fields were not done, and by only OCT, the patient is diagnosed as advanced glaucoma. Once the patient is repeated, the fields are almost early glaucoma. Treatment is started, and this patient was under my care since 2016, and the fields are maintaining without any progression. This is the case 5. Again, if you see, there is no clue from the fundus. If at all there is clue, there is notch may be starting here. Otherwise, it is a uniform rim, and there is no nerve fiber defect. And this patient is also labeled as advanced glaucoma on the basis of OCT without fields being done. The signal strength is good, but if you see the segmentation of the retinal nerve fiber layer, the segmentation is not proper. If you see the rim marking is also not proper. So once you take the field, the right eye field is absolutely normal. And the left eye field is showing very early field defect. And because the tensions are around 21 in both the eyes, actually I put the treatment for both the eyes. And followed after 1.5 years, the patient had a disc hemorrhage, and the field defect started. You see here the field defect in the OCT is not having, it is also almost normal field and a normal OCT. Here the OCT is showing normally the field defect should be here. OCT is showing yellow mark, and this is another field defect. But the patient had, even though the patient is on treatment, he had a discamrus. So this is the 5th case. Now coming into 6th case. Here also the patient, I saw the patient in 2006. Almost the rim is excellent, and only couple the disc disparity is there between these two. Right? The fields were taken in 2006. They had lower arcade scotoma. Here this lower arcade and biarcade scotoma. A well done field, 24-2 is the standard. And because the IOP is on higher side, the patient was put on treatment from 2006 to almost 2012. She was in my town and under my care, and very stable fields. And when she left the place due to some transfer, and she diagnosed as a physiological cup and stopped the treatment. And again, I saw this patient in 2016 with the advanced cup. See, this is the 2006 fundus photograph, and this is the advanced. And you see, there is no nasal shifting of the vessels. The rim is lost, rimless. More in advanced. At this stage, I had to do trabeculectomy, and the patient also had the cataract combined, and the extraction was done, and the patient. Up to now, if you observe, all these cases, the glaucoma started almost beyond 15 degrees periphery, starting from the periphery. When the glaucoma starts from the periphery, it may be difficult to, it may be changes in the disc, they appear late, and almost the disc looks normal. And the only clue may be the rigid IOPs. As the field, now I will be talking another 3 cases where the definite clue is there: nerve defect, a notch, nerve defect with a notch, and advanced rimless disc with a diffuse nerve loss. So when the field defect is coming towards the center into the 10 degrees and increasing the depth of the field defect, the signs will appear. Once the signs is nerve fiber loss with rise of tension, now it is an established case of glaucoma. So in early case, in a suspected case, we always concentrate on the reliability indices, try to be 100% perfect. Glaucoma hemifield test and PST should be abnormal, and Anderson's criteria, the field defect, 3 points with a p-value, 1 point p-value less than 1%, and 2 points will have p-value less than 5%. So once that is for diagnosis. Once in established case of glaucoma, our aim is to set the target. When the target IOP, I told you the minimum 5 things. What is the depth of the field defect? What is the location of the field defect? What is the direction of the field defect? How is the foveal status? All these things should be considered to set the target IOP. So whenever you see, you always see a field defect, you try to locate from where it is starting. The identification of the deep scotoma is the starting point and how it is progressing. Identify the deep scotoma, and it is coming towards the center, and it is also going like this. And the mean deviation, as you know, in a localized scotoma, it is the average. When all these deep scotomas values, when expressed as a mean, it is only minus 4.97. The mean deviation gives the average of all the points included, and in localized scotoma, it gives you undervalue. And the field defect is also corresponding in the OCT. And the 8th case, this is the nerve fiber defect. So it is an established case of glaucoma, 24-2 is the standard. And if you see the always this deep scotoma is here, 9, -9, -10, it is going towards periphery and going towards an arcade pattern, also coming towards the center. So if this becomes, you have to observe the next visit. What about this part? How is this part? It is -4, whether it is increasing. If it is increasing, that means it is coming towards the fixation. So the depth of the scotoma, the mean deviation is -3. The location is periphery started and coming towards the center. The extent is occupying 1 quadrant. And if you observe, it is not absolute scotoma. It is a relative scotoma. Still, the relative scotoma is producing nerve fibrillary defect. So, nerve fibrillary defect doesn't mean that it will produce an absolute scotoma. A relative scotoma can have retinal nerve fiber. Is the left eye field effect just like the right eye, and the location of this is the area from where the glaucoma started and progressing arcade pattern with a mean deviation of -3.5. You see, if this is a well done, the signal strength more than 6 is we have to take it for it is okay. 8 and 7, and you see this is the marking of the internal membrane, and this is the marking of the Brooks membrane opening, and the distance between the Brooks membrane opening and this is the main membrane. Brooks BMO MRW, that gives the rim. Very well segmentation and vertical and horizontal sections of they are excellent. So the OCT can be taken as into a reliable OCT, and the diagnosis, because it is established, and the depth and foveal status are very good. Single drug regime can be started for that. Now, you see this glaucoma still more advanced. It's almost coming into the 10 degree, and you are seeing full-blown glaucomatous disc, rimless disc with a diffuse nerve fiber loss. You see, this is the 24-2 with good reliability. Even though the patient is having almost here up to even in 10 degrees, the reliability, the false negatives, false positives and fixation, excellent fixation. False positives also 0, false negatives are 99%, and the mean deviation is -15.64. Once it is an established case of glaucoma, we don't give much importance to the PSG and the glaucoma imaging. We are more concentrating on the depth of the scotoma. Always see the within 16 points within the 3 degrees of 24-2 for indication of 10-2, and we repeated the 10-2. Yes, and you see it is almost coming into the 3 degree point. There is 1 degree point. 3 degree point is also involved. Yes. The left eye is also. You see this thing. Almost it is now spreading into the lower quadrant. Upper quadrant almost absolute scotomas. It started spreading in the lower arcade scotoma. Recent onset. So it is actually progressing field. You need not have the follow-up field to say whether it is progressing or not. Even in the same field, it is no. When it is converting to pattern deviation plot, the superficial scotomas, they disappear. That means if the patient is already on say medication, whatever the medication, anti-glaucoma medication is taking, actually that is not enough. It is now if the disease is progressing, we have to increase the dose or you have to go for surgery. The left eye is also, see the bitemporal biarcade scotoma. Now, this is the superficial. You see, they are superficial scotomas. You need not even see the mean raw data to know whether it is superficial or not. But if they disappear in the pattern plot, that's superficial. -5, -5, -4. You see, they are all around 30s. And if you see the absolute, among the 16 points, the absolute scotomas are there. When an absolute scotoma is there among the 16 points, you repeat the test with 10-2. We are seeing the 10-2 also. So here, 24-2, an indication for 10-2 is there. Repeat the 10-2. The mean deviation of 24-2 is -12.83, and the mean deviation of 10-2 is -13.89. So you should have always to know how the progression is occurring in 10-2 and how the progression is occurring in 24-2 and 10-2. So this is the conventional concept. The glaucoma usually starts to the center. In advanced case of glaucoma, we take the 10-2 to know the residual field. That is the original concept. But In type 2 glaucomas, what I say, the glaucomas can start within 10 degrees. I will be showing you 4 cases where glaucoma starts within 10 degrees. This is the first case. The glaucoma, you see, the most important point, the glaucoma starts within 10 degrees. Usually, the appearance of the cup is not magnitude to the field loss. It is not proportionate to the field loss. Because if I will compare this 10th case to the 9th case. Now we will see 9th case. This is a nerve fiber defect. This is the nerve fiber defect. When the nerve, you see when the nerve fiber defect is there, you always see from where it is coming. Actually, it is coming from the fovea. This is the clue that gives that, and it is going towards the macular area. And these patients, you see, this is the rim is well done OCT. This is the field. This is the deviation map. The deviation map will have only 2 colors and yellow color. Red color means deviated more, yellow color deviated less. And there is an articular defect. And the macular ganglion cell analysis is also showing the loss of ganglion cells. And 10-2 is a useful defect. If you see the 10-20, anyway, once you suspect, when you see glaucoma, when you ask for fields, always ask for visual fields 24-2 and see whether there is an indication for 10-2 or not. Always start with 24-2 printout with a SETA standard. And once you see the located in the center defect is there, always you see what is the depth of the scotoma. Here you see this is absolute scotoma. 0 in the raw data is absolute scotoma, started on the 3-degree point and which is going outwards. Started within 10 degrees, minus 32. And once you see, even 1 in 2 absolute scotomas are there, and the remaining points gross only minus 30 and minus 8. Other points are almost there. But when you see minimum 1 absolute scotoma, you always ask for 10-2. When the 10-2 is asked, see, the mean deviation index is minus 12.84, and almost, if you see, it is almost going into the 1-degree point. And this thing. Because the left eye, there is only 1 scotoma in the 24-2. Because the right eye is having a field defect in 10-2, the 10-2 you see, the 16 points of the raw data. See how best they are their points. Only 1 point is the 3-degree point is 14 dB, that's minus 90. Otherwise, the 0 means in a total deviation, 0 means normal point, no 0 deviation. It is the point is in the middle of vision. Only 1 point is there, and even 1 point gross defect is there, and you ask for 10-2. And this printout, actually, this field defect is crossing between, this is the 3-degree point and 9-degree point, and it is going in between the points. That is why this is not picked up in the 24-2. And with the mean deviation, minus 1.23. And the OCT, if you see the OCT, is a 2017 patient seen. The OCT also did not pick up. The nerve fiber defect is normal, and because if you see the disc size is very small. When the disc size is very small and the field defect is coming from the fovea, usually the field defect, the OCT may not able to pick up the field defect. But actually, if you ask, this is the 2018, the same patient, there is the 18 field, there is slight increase in the patient's mean deviation index, and this 18, this field defect appeared. Still, the field defect did not appear in the OCT. But if you take the 10-2, this ganglion cell analysis, there is a huge effect in the ganglion cell analysis. So, most important thing is taking the correct point. In this patient, if you don't take the 10-2, you are likely to miss. If you don't ask for ganglion cell analysis, you are likely to miss. So, the most important thing is asking for the correct test, whether you want 10-2. This is actually this OCT is optic nerve head tube. And this is the ganglion cell tube. So you should ask the ganglion cell analysis. And macular tube. This is the macular tube. Macular tube gives you the thickness of the ganglion cell and the nerve flexiform. And it gives the, so whenever you see glaucoma starting within 10 degrees, along with the this optic nerve head tube, you also ask the macular tube. And if you have both, they can be printed in the same printer, the macular tube and the optic nerve tube overlying. You can have this, it is called as span analysis. By comparison, if you compare the 9th case and the 10th case, I told you the appearance of the disc is not proportionate to the field effect. Because here the 10-2 almost in both the cases, almost the magnitude loss is same, but here the peripheral fibers are normal. Here the peripheral fibers also involved, and see the color of the disc is very healthy. If you miss this nerve fibular defect, and it may be mistaken as normal disc in spite of being a huge field defect. And here this is the difference. And see, so whenever the glaucoma starts within 10 degrees, the appearance of the disc is not directly proportional to the field loss. Whenever this is the field defect started, this is the 11th case, started within the center. Whenever you see the field defect, a black square means it has only the p-value is less than 0.5%. A black square can be beyond 8 dB loss. It is represented by black square. A black square never tells what is the depth of the scotoma. You always see here the -35, -30. So the glaucoma started at the 3.3 degree point and started outside, going outside. And this is the absolute scotoma. Therefore, when you see the 16 points of the raw data, central 16 points, the 3 absolute scotomas are there. You ask for 10-2 and the field defect is there. This is 12th case. Once you are seeing a field defect, and this is a nerve fibular defect, and you are seeing upper nasal scotoma, the upper arcade scotoma, and always go and see that what is the depth of the scotoma here and where is the deep scotoma. You see, this is the deep scotoma starting -34, -34, and it is going this periphery from the center. And you see the 16 points within the 3 degrees, whether the indication for 10-2, there is a, so you always see all these cases are known cases which started within 10 degrees. So always see the raw data and have an idea what are the values of the 16 points. And here there is an absolute scotoma. There is no doubt that you have to go for 10-2. So for when the test is repeated with the 10-2, there is a huge scotoma. Within 3 degrees, what are the within 3 degrees of the 10-2, the 16 points, and what are the return sensor? Luckily, within 3 degrees, the field is almost very good except these 2 points. And it is not coming towards fixation. It is going away from fixation. That is one thing good in this patient. Okay, 129, 33. Here 30, 27, 31, 33, 30. And so once you decide, you know that it is 10-2 field, you should have both the baseline printouts 24-1 10-2 for progression analysis. This case I told you in the during last talk. This is the known patient of glaucoma, the cataract with a nerve fibular defect, and taken the field in March. There is a generalized depression with a localized field. So to identify the generalized depression, to identify the localized scotoma, in a generalized depression, the pattern plots are created. So this correspond to the absolute scotoma here, representing in the grayscale, representing the pattern and total deviation numerical plot, masked in the generalized depression of the total deviation probability plot. This localized scotoma is highlighted. And you see within 16 points, and the absolute scotoma is there. Otherwise, the remaining points are -8, -6, because this is due to cataract, and -32. There is an indication, and the patient I saw in March, I operated the patient. You see this cataract is extracted, so there is no generalized depression in the total deviation plot. There is a scotoma, the cataract starting within 10 degrees. Here, actually it is going in this direction. Okay? And the patient in May, I operated in April, and the field is taken. If you see the fundus, the appearance of the disc is not proportional to the field effect when glaucoma starts within 10 degrees. And these things actually, if you take the OCT in this in the right eye, the OCT is almost looking normal, this optic refractive tube. But if you, I had the macular tube, it gave beautiful the ganglion cell analysis. So from this you understand the glaucoma starting within 10 degrees, the appearance of the disc is not proportionate to the field loss. And now this type 3, where glaucoma starts both within and outside 10 degrees. Again, the appearance of the disc depends upon the damage of the both, of the magnitude of the damage will reflect the appearance of the disc. See here, this is the 3 cases, the 14th. So what, when the glaucoma is suspected, you ask for field. This is the field, the biarcade scotoma. And if you see this scotoma, we never know that it is having glaucoma started at 2 places. But I told you the importance of the grayscale. The grayscale gives you the multicentric origin of the glaucoma. So the glaucoma started here one place, here another place, multicentric origin. But if you see the probability plot, it looks like as if it is a single biarcade scotoma. But the pattern plot, if you see, these differentiated. This is the one field -23. This is the upper arcade. And if you see the raw data, in the raw data, only 1 point is there minus in the total deviation numerical plot -23. Always R1 -9. This 9 dB, this is 9 dB, this is the retinal sensitivity value. Other points, the retinal sensitivity is very good. So even with this, the retinal sensitivity within 16 points, we know this is the raw data and the patient had the field effect in the 10-2. The mean deviation index of -7.20. And because the peripheral fibers are good, see, this is the, it is looking healthy rim. This is the nerve fiber, big nerve fiber defect going towards the macula. This is another case. By seeing the grayscale and the probability plot, we know we started as biarcade with a central degree also in normal. You see, whenever you see, you go again see the depth. Here, absolute scotoma is absolute scotoma, -32. And if you see, the defects are -22, -29, 11, 14, 13. So the periphery is not, it is actually, the loss is not high. That is why, if you see, the loss is only mainly in the center. Periphery must be started very recently. That is why the appearance of the disc is not to the magnitude of the field loss. This is the 10-degree loss in this. This is so most important is by seeing the disc. Sometimes if nerve fiber is not appreciated, we are likely to miss this. So this is the 16th case. You see this, the rim looking almost healthy, but there is a nerve fiber loss is there. This is the nerve fiber loss. In the OCT also you are seeing the nerve fiber loss here. In 2011, I saw this patient. Only they mean the 24-2 Sstc standard and well done field. False positives are 1%, false negatives are 7%, and fixation losses 1/18. You see there are 3 scotomas. You see, always see what is the, it is absolute scotoma. This point is absolute scotoma. Otherwise, the other points of the 16 points are good retinal sensitivity, only is -35. And actually, I didn't do the 10-2 in 2011 because my knowledge at 10 years back regarding the coma starting within 10 degrees, what I have today, I don't have that concept. Then this 2012, I did the 10-2. Once I did the 10-2, there is a huge scotoma. And even this scotoma, even in 10 degrees, you see started on the 1 degree point. So, we know, now we saw these cases, how to, well, we had to diagnose the cases to have the correct baseline fields. So, diagnosing glaucoma and setting the, depending upon the location and the extent, depth, direction of progression, and therefore macular status, the target will be decided. So once you start the treatment, our aim is to arrest the progression. To arrest the progression, we must have the correct baseline fields. So in all the cases I told you, whenever you suspect or establish or diagnose glaucoma, always ask for 24-2 and see the indications, whether they require 10-2 or not. Now you saw in many cases, how are the values of the points within 10 degrees of 24-2. Now we will go in depth when to repeat the test. As you know, in conventional concept, by seeing the 24-2 printout, we can straight away go for 10-2. But we are now seeing the field effects quite often starting within 10 degrees. This, you see this printout. You see this printout. Likely we don't ask for 10-2. You see this printout, you don't ask for 10-2 unless otherwise you know that the glaucomas can start with 10-2 with minimal defects in 10-24-2. Then you start seeing, if you see the grayscale. So the most important thing in the interpretation of the grayscale, you see within 10 degrees, the appearance of the brightness. Normally this, if you see the grayscale, even from a distance you can tell that this is a defective grayscale because the here within 10 degrees, the foveal sensitivity is more than 34, 33, 32. And when compared, it is a bright, the brighter, within 10 degrees, the brighter shade should be there. And here the brightness is lost. Is already the superficial scotomas, they appeared in the 10 degrees if the brightness is lost. The shade need not come. So it is appreciated in the probability plot. So the most important thing is the loss of retinal sensitivity within 10 degrees is better appreciated in the probability plot, but it is appreciated in the grayscale also if your mind doesn't know to interpret the losing the brightness in the within 10 degrees, the losing the brightness will not be picked up by our brain. And we wait always till the black shade comes. Here also, the brightness is totally, here it is lost. Here the brightness is there. So now we will see. This is the conventional concept. But normally, which gives you the clue to go for 10-2. Identification of type 2 and type 3 glaucomas. In fundus, the retinal nerve fiber layer, the direction, normally it comes from here. We always say it is going. Normally, the retinal, the axons of the ganglion cells, they come like this, coming from the fovea. thinning of the retinal nerve fiber layer going towards the coming from the fovea, and concentrate on the 16 degrees points of raw data and the total deviation numerical plot of 24-2. Concentrate on the grayscale at the central 10-degree grayscale in 24-2 and print out, and concentrate the probability plot on the within 10 degrees of 24-2. So from the probability plot, the 16 point from the grayscale and the 16 points of the central 16 points of raw data and the total deviation numerical plot, and the nerve fibular defect going towards the fovea. And the OCT, you see a nerve fibular thinning going towards the fovea between 7 o'clock to 8 o'clock, or 4 o'clock, 5 o'clock to 4 o'clock. If you see the direction, and it is towards the, if you see the periphery, 6 o'clock or 12 o'clock, that means the fibers are coming from the periphery. So OCT also will give us a clue from where the fibers are coming. So in only in when we go for 30-2 in type 1 glaucomas, in type 2 where the glaucoma is coming almost towards the center, we ask for 24-2. I told you why we ask for 24. Normally I told you you go for 24-2 instead of 30-2. Only when the glaucoma starts from the periphery, that is one condition where we ask for 30-2. Why you go for 30-2, 24-2, not for 30-2? Because while selecting the best seventh deviation point, outer set of points of 30-2 not considered, visual field index calculating outer set points of 30-2 are not considered, outer set of points are not considered, and Anderson's criteria outer set points of 30-2 are not considered, and these points will be tested last, so chances of getting false negatives and fixation losses are very high, and the test will become unreliable because of these 5 factors. Because in the PG exams, they may ask why you want to go for 24-2 instead of 30-2. Then you have to tell all the 5 points why I will go for 24-2. So in this way, I will take the one patient. This patient actually started from 2011. I will now give you up to from 2014, 17 and 18. If you see 2014, 24-2, here the probability plot is showing the defect. And now I will go to the next slide and I will tell you. 2014, already the field defect started in 10 degrees. If you appreciate the loss of brightness, here the brightness is there, here the loss of brightness is there, and the probability plot is showing scotoma. And if you see the raw data, see there is no gross defect. 0 in total deviation numerical plot is normal, no deviation. A 0 in raw data is absolute scotoma. There is no 0, there is no gross loss, except -6 is there, -7, -6, that is the loss. Still, we have, see the other eye having a large field defect within 10 degrees, and this eye, because of the other eye, this field, the 10-2 was taken. If the other eye is also like this, with this, usually if you do not know, if you see a black square in the probability plot, you must ask for 10-2. Because this scotoma is traveling between here 3 degree and the axis, and it is traveling between these 2 points, and that is why. But the brightness of the area is lost. This is 2017. The brightness is lost. There is absolute. There are black squares are there in the probability plot. And if you see, they are superficial. So any loss of retinal sensitivity more than 6 dB or 7 dB will be represented by black square. So there is a black square and the superficial loss. And because it is superficial loss, we don't see dark shade. The brightness is lost. It is around 30 dB because this is the 29 dB and this is the 30 dB loss. And still it is passing in between the points. And you see there is no absolute scotoma, there is no gross defect. Still, we have to go for. So you keep all these things in mind. When to repeat the test with 10-2. With these values also, sometimes we have to repeat the test. Once we have a clue from OCT, once we have a clue from the fundus examination that the retinal nerve fiber layer is going towards the macula, you have to go for 10-. In 2018, the shade appeared. So, and the black squares also increased in number. So the most important clue from the beginning, if you see, the probability plot gives you the earliest clue to repeat the test with 10-2, and the disappearance of the bright shade in the within 10 degrees in the grayscale, and there may be minimal deviation points will be there. And because in this they see 24-2 is more stable, and 10-2 this disease is progressing in spite of the treatment. And I have to go for trabectectomy at this stage to arrest the progression in 2018, and the patient is now this field is still. This is the another case. If you see the nerve fiber layer is going towards the fovea macula, and see the minimal. This, if you see the raw data and the total deviation numeric plot of 24-2, only one point is having -33. This is absolute. All the remaining points are normal, but you see a huge nerve fiber defect, and here the field defect is causing in the point. That is why here it is not. This defect, this is different field defect, not related to this, and this is somewhere here. And you see the field almost the disc is small, but then there is no rim loss, and appearance of the color of the disc is also very good. So they are not proportionate to the field. So with this background, now we analyzed the field, the single field analysis printout. So analysis of the single field analysis printout in diagnosis, our main aim is you always ask for set a standard and try to be the reliability. This is 100% perfect, and concentrate on glaucoma hemifield test and the PSD. The PSD is the sign developed to pick up early glaucoma, which indicates irregular deviation values in the total deviation numerical plot. It is not indexed to tell the depth of the field defect, and it doesn't carry any sign, and it is included in the Anderson's criteria and glaucoma hemifield. Once the glaucoma is diagnosed, our aim is to set the target IOP. So target IOP, it depends on the location of the field defect, extent of the field defect, depth of the field defect, direction of the field defect, foveal foveal split, but status. All these things will help you to set the target IOP. And whenever you see, always whether this patient requires 10-2 field also, you concentrate on the 16 points, you concentrate on the fundus examination. And mostly the glaucoma starting with 10 degrees, they will have 100% nerve fiber defect. Once you see a nerve fiber defect, you always should follow the nerve fiber defect from where it is coming. If it is coming from the fovea, we have to go. And if you see in OCT, always better to have a baseline OCT also, even in established case of glaucoma, not for diagnosis. You have for the progression analysis, OCT also plays a major role. And once you see the field defect is going towards the macula, you always ask the macular tube, which gives you ganglion cell analysis. Now coming to the methods to pick up progression. There is no standard method to detect progression, and always nothing to replace the clinical examination. So uncontrolled IOP, not putting the drops, they give the clue for progression. And never see the visual fields in isolation, and always correlate with the fundus, and always evaluate the risk factors and have a correct baseline. Normally, the baseline field and the follow-up field, if there is increase in mean deviation, that is a sign of progression. The progression can be deepening of the existing defect, enlargement of the existing defect, That is, enlargement is the horizontal progression. Deepening is vertical progression or onset of nucleus.
81.
So no change in the no change in the mean deviation, or there is no progression. There is a change in the mean deviation is increase. That means there is a progression. Always see the change in mean deviation is not due to the fixation losses or false negatives or due to the bulb or the size of the pupil. You have to consider all these factors and other diseases causing defective vision, maybe cataract or any macular pathologies, diabetic retinopathies, macular CSMEs, or CNVM. All these things you have to eliminate, and you have to assess this change in mean deviation is purely due to glaucoma. If there is no progression and if there is no change in PST, that means it is a uniform progression, mostly due to cataract. If there is a progression with change in mean deviation, that is irregular loss, that is a localized progression is. So I told you change in mean deviation in localized scotoma always gives you the lesser number. Even a 2 dB change in a localized scotoma in compared to one quarter, that is huge. Don't think that is only 2 dB. A change in localized scotoma is 2 dB is also is a high magnitude. In a generalized depression, 2 dB is not that magnitude. So in overview printout, this is the event analysis. What is the in overview printout is this is the different format of the single field analysis printout. All the components of single field analysis printout will be in the overview printout except total deviation numerical plot and pattern deviation numerical plot. These two plots are not there. Otherwise, all the components of the total this single field analysis printout is there. All grayscale, the raw data, probability plots, how the fixation losses, fixation, false negatives, false positives, PSD, mean deviation, glaucoma hemifield test, all will be the overview printout. Whenever the overview printout is there, you see the change in mean deviation. What is the mean deviation of this test? And the parameters must be the same. It must be theta fast and theta fast, 24-2, 24-2. Because the mean deviation of 24-2 cannot be compared with the mean deviation of 30-2 because it's the average of 74 points and 24-2 is the average of 54 points. 2 points on the blind spot, they will not be considered. So, and the foveal sensitivity, always see what is the foveal sensitivity of the first test and the next test. If the both are good, that means no cataract and the refractive error corrections are given proper. If there is a change, then we have to consider. Sometimes the patient may be long learning curve. And see, in 2015-2016, to get the correct values, fixation loss is 0, 0, 0, the mean deviation is -7. To get all the three to 0, it took me how many tests I had to do in 7-8 times. Some of the tests I didn't include. 35% here, false negatives, 36% here, false negatives, 40% here. So to get the things to normal, and you see the mean deviation of -13 came to -7. So this is another example how we have to evaluate. You see, in June 2015, fixation loss is 0, false positive 0, and false negative 16%, mean deviation is -25. In 2016, fixation losses are 0, false positives are 0%, and fixation losses, false negatives are 27%. The mean deviation is -15. Normally, the false negatives are increased. If the false negatives are increased, the mean deviation also should have a higher number than this. Then where went wrong? If you see the raw data, you are seeing an inferior sign in front of one. That means the bulb is not proper. That is why we are getting the wrong report. Once the bulb is replaced, you see, this is the correct report. And here, because of this, so we have to correlate everything. Then only you will pick up. If you don't see the raw data with inferior sign, you compare and something is going wrong. So this patient, so selection of the point patterns. Here, advanced case of glaucoma, and 10-24-2 is selected, and 24-2 the mean deviation is almost stable. And if you see in 24-2, almost all the peripheral points are absolute square. Only few points are having retinal sensitivity. Then when we consider mean deviation, only the changes in these few points will be distributed to among all the points, and mean deviation will come. So that even there is a gross change, when it is expressed in a mean, the minimal change will be there. You think that the glaucoma is stable there because there is no change. So always select the correct point patterns. Instead of 24 dash in advance, you must have 10-2. Whether you have 24-2 or not, but you must have. Now, this patient seen in 2003, very early glaucoma. Here it started, and last the follow-up. Again, I saw this patient in 2016 after 13 years with a branch vein occlusion and advanced. If you see, even in this thing, originally the glaucoma started here within 10 degrees. And fortunately, it went outside and did not progress toward the fixation. That is why I told you, this almost started here and did not come to the center within 3 degrees. It is going away from the fixation. I saw this patient in 2005. Small discs. Very early, started outside 10-degree circle almost, and this is actually 3-degree circle. This is the 9-degree circle. This is the 15-degree circle points. This is the 21-degree circle point. This is the 27-degree circle point. Even in 24-2 also, because the 2 points on the nasal side, they are not eliminated. The outer 22 points are eliminated, keeping the 2 nasal points. So they are 27-degree points. Even in 24-2, we have the points on 27-degree circle. And started from the periphery, both eyes, the treatment started, but she's went to see if she belongs to a distant place. Instead of putting drops, here almost somewhere she left, and the doctor advised you can put only drops in this eye, and you need not put in this eye. She started putting the drops only in this eye, and then put the drops in the correct eye. When I saw in the 2016, she stopped putting the drops in the right eye, and she is putting on the drops in the left eye, and it went in 2016 I saw. And so whenever the patient, even you diagnose early, what is the use? The eye went into advanced glaucoma. And so whenever the patient, you ask, always better to ask the patient come with the drops and ask them what drops she is putting. Sometimes they may be putting somewhere lubricants, and they may tell you that I am putting the drops. And tensions may sometimes may be normal tension glaucomas, and you may miss the diagonal piece, and the progression may be there. Always ask how he is putting the drops, what type of drops she is putting, and whether she is putting the nasal punctum, and analyze. Otherwise, diagnosing the case early doesn't mean anything. This patient seen in 2006, 2016, 2018 up to 2020. I have been following for the last 15 years. See the fields almost looking stable. Mean deviation -5, but here slight increase is there. And if you see this patient, the raw data is coming towards here, it is 12. 12 became absolute glaucoma. When I took the field, see this field going between the points, and it is not appreciated in the 24-2. Because it is going in between the points. And you see this field effect started here also. So always it's the same patient. Field effect in 24-2 is went up to -4 to this visit, 2017 to 2018. But up to 2006 to 2017, almost stable. So in 10-24, this 10-2, this is changed from -6 to -8. So I did actually trabeclectomy in this patient to stop the progression. If you take the OCT, this field, this pickup, this field is almost normal. And always, if you see the ganglion cell analysis, this will come positive. And if you see the rim is actually, this is a small disc, only 1.89, this small disc. So in all small disc, you are likely to miss the nerve fibrillary thinning. This thinning is missing, but well appreciated in the ganglion cell analysis. This is the patient. So here, whenever there is a patient in the probability plot, once a black square appears, even it is actually a black square, the loss may be -8. Further loss will not be appreciated. It remains as a black square. And if you see the probability plot, you see the increase in that. So there is a change in mean deviation -7 to -12, but there is no change in the probability plot. So vertical progression, once a black square appears, the vertical progression at that point will not be known, but better appreciated in the rest. So mean deviation -7 to 12, no change in the probability plot, change in the scale. So the patient is more stable. And here we think that here this is the total loss is there. Once the cataract operated, the mean deviation becomes normal. The stable glaucoma, this field is cataract. Take for example, so to have the correct baseline fields, this patient both starting within 10 degrees and outside 10 degrees. And mean deviation 2000 to 2017, it's actually improved. But you see in 10-2, the mean deviation -4 to -8 almost. You see we lost the brightness and it is appreciated the probability plot here. And the depth is slightly increased, then appreciated in the. So the losing the brightness within the 10 degrees circle, well appreciated in the probability plot. Again, the correct baseline fields is there, should be there. 24-2, almost stable. And here it's like, even in 10-2 also, is a stable field. This is event analysis, how the things are going. What is the 2017, 2018, what is the mean deviation change, what is the visual field index change, this table. So here, if you see probability plot, there are also persistence controls. And the loss of, here you see this open. The brightness is lost. The biarcate within 10 degrees. So most important thing is because we don't appreciate once a black square comes, the vertical depth is not appreciated. For that purpose, the progressive analysis probability plot came into existence. Suppose this now, if you see the progressive analysis probability plot, if you see the normal talk, no loss of retinal sensitivity at this point. If you see a triangle, open triangle, identifies a degree of deterioration expected less than 5% of the time at that location in a stable glaucoma patient, p-value less than 0.5%. If you see half triangle, actually it is a full triangle, empty triangle. This is half blocked triangle. Half blocked triangle means at this point, the deterioration is there in the two consecutive tests. So the loss of sensitivity, maybe it is a black square. The loss of retention is more than 8 dB. 8 dB may, if it comes to 10 dB or 13 dB in the next test. And again in the next test, it may be going into minus 20 to 4 dB. So there is a deterioration at that point, two consecutive tests. Because it is a black square, we are not appreciating. But in the progressive analysis probability plot, it is represented by half-filled triangle. So we know this black square is deteriorating in last consecutive test. If it is a full triangle, blocked triangle, three consecutive solid triangle indicates significant deterioration at that point on three consecutive tests. So it tells that that point is losing, deteriorating for the last three tests. So by seeing the black square, we do not know. But if you see the raw data, if you see the total deviation plot, the deterioration is expected. But by seeing the probability, progression analysis probability plot, we know which points are deteriorating, which points are not deteriorating, which points are outside the analysis. So coming into the rate of progression, the most important thing is whenever you diagnose glaucoma, the glaucoma can be of two types: fast progressing and slow progressing. So to know which cases are fast progressing and which cases are slow progressing, you must have, once you diagnose, the first year you must have 3 fields, next year you must have another 3 fields. Almost every 4 months, you must have, within 2 years, you must have 6 fields. So by having 6 fields, we can know what type of glaucoma it is. Is it a fast growing progressing glaucoma or slow growing progressing glaucoma? So once you assess it, afterwards once in a year you can depend on that. So minimum 6 tests once diagnosed, every 4 months to have 6 tests in 2 years. Afterwards you can have, depending on the indication, you can have the test to assess the progression. And the glaucoma progression analysis, which is based on the normally on VFI, visual field index. But most important thing is visual field index is not present in 10-2. So the progression analysis of the fields in 10-2 cannot be made from glaucoma progression analysis. It has to be on the mean deviation index. There is a likely to be progression and progression possible. Printout will give once you have the minimum 6 tests and GPA. Printout will. Some of the I have the emails from some of the students to explain the the conversion of total deviation to pattern deviation. Few slides I will show you. So you know how to identify the 7th best deviation point. You identify the 7th best deviation point. So there are 6 points better than the 7th best deviation point, and there is another 1 point equal to almost 2 points are the same. So in this thing, this is minus 15, and these 6 points are better than the 6 better points. The 6 points are there, minus 4, minus 9. These are the better points. Among these are the better points. These 2 points are 7th best deviation points. So identification of 7th deviation point, and you got 6 points better than the 7th deviation point. Now the dB value that converts 7th best deviation point to 0. That means the dB value that brings the 7th best to hill of vision. This point, hill of vision. The dB value that brings the 7th deviation point to 0, that means to the hill of vision, is added to all the points. So the better points will go above the hill of vision. The 7th best deviation point comes to the hill of vision, and the remaining points, they come upwards by the dB value. Here 7, whatever the deviation value that brings the 7th deviation, best deviation point to normal, is added to all the points. So out of these points, the points nearer to the hill of vision, they are superficial scotomas. They also may lose the significance. These points, they don't have p-values. So these points, minimum 6 point, 7 point here, these points will not have any p-value. These points will not have. So 8 points will not have any p-value. And these becomes superficial. So uniform depression, if you see, the seventh best deviation point is here, 7, and the better sensitive points are there. How many points are there? 6 points are better than normal. If you see the seventh best deviation point, the value that brings seventh best deviation point to normal is added to all the points. So these points will become above normal, and all these points will occupy. And once they come nearer to the normal linear vision, these points will not be represented by any significant p-value, and they look uniform depression. So in uniform depression, the points after conversion, they will be nearer to the hill of vision. That is actually perimetric definition. Whereas in localized scotoma, already the points are on the hill of vision. The seventh best deviation point will be either on the hill of vision, or maybe better than normal sometimes, or very close to the hill of vision. So the dB value that brings to the seventh best deviation point to the normal is very minimal. So we don't add anything. So when we don't add anything, both the total deviation and pattern deviation, they look similar, and their flash will be. So thank you for giving the opportunity to talk to the PGs on the visual fields. Then we will talk about any doubts. Dr. Professor Tanuj Dada is there, and he will be answering along with me. Thank you for the giving opportunity.
Thank you, sir, for your very informative talk with an excellent explanatory examples. The house is open for discussion. Any questions? Sir, I myself have one question. Sir, if we have a patient who presents for the first time to our hospital, and the patient is one-eyed, has lost the other eye because of glaucomatous optic atrophy, and the one eye, there is an advanced cupping present, the IOP is on a higher side, the patient is already using some medications but not very compliant with the treatment. There are no any documented fields. So sir, in these cases, we cannot keep number of fields like as mentioned that we should have minimum 6 fields as a baseline, or at least minimum 2 fields as a baseline, and to assess from third fields onward. So sir, in these cases, how do we assess the progression, and how do we decide that we can now go for a surgery in these patients if the IOP gets controlled with the medications?
No, when it is already, you are telling it's one-eyed.
Yes, sir, it's a one-eyed.
And it is advanced.
Yes, sir.
Who you say advanced?
Sir, if we say around 0.8 to 0.9.
No, by seeing the disc, normally you can't tell it is advanced.
Sir, but if the cup disc ratio is around 0.9.
Okay, it is advanced, and you go for the field. Once you diagnose glaucoma, you go for the field first time.
Okay, so but if this is going to be the first field for the patient,
whatever it may be, okay, have a baseline field. You need not have 2, 3, 4. If already it is advanced case of glaucoma, and they have taken the field, now you assess the field effect. Now assess the field effect. If it is reasonably good, otherwise, if it's so advanced, you go for macular program with size 5.
Okay.
And if the patient can do with 10-2 with size 3, you go for it. And if it is a reliable field, now you assess the field effect. What is the macular status, and what is the IOP? What are the other risk factors? And now your aim is when to go for the surgery.
Yes, sir.
So why the field effect so advanced? Does the patient lately diagnosed, recently diagnosed,
the patient was
diagnosed long ago and not putting the grafts properly?
Yes, sir. The patient was diagnosed but was not compliant with either.
How many years back the patient was diagnosed?
Sir, nearly 4 to 5 years back the patient was diagnosed first time.
4 to 5 years at what? stage the glaucoma is diagnosed? What is the magnitude of field defect when the patient is diagnosed?
So at that time, the baseline fields were not done for the patient.
Field was not done.
Yes, sir.
Without any field, he is putting the drops.
Yes.
And therefore, we do not know. And what is the present IOP with the drops?
So the present IOP was 21, and he was using 2 anti-glaucoma medications. And he was also not very compliant with the medications that he was using.
So whatever it may be, if the same thing continues, the patient is going to become blind. So you have, because we cannot keep it, rely on the drugs. So if you are very confident surgeon, you go ahead. Otherwise, you refer to a competent surgeon surrounding you, because it's one-eyed. Our aim is to save the eye.
Save the vision.
Because the decision of anti-glaucoma surgery varies from surgeon to surgeon. If you are a confident surgeon, you don't delay the surgery. If you are not confident surgeon, you will delay the surgery. Here you cannot, because you are going to know this patient is going to become blind if you cannot control eye. It is only by surgery. You have to, you need not have a baseline field, you need not have another drug, and you go for surgery. Sir, what is your opinion, sir?
No, I totally agree with you. Patient, one-eyed patient, advanced glaucoma, pressure 21, on 2 medications, very unlikely he will get controlled. If possible, he should get 10 or macula fields done, and he will have to be undergo surgery because target pressure is not going to be achieved. But it is better to have at least documentation of the visual field, because one is that he will be at risk for complete vision loss if the visual field is very narrow. Second thing is he will be eligible for visual disability if the visual field is less than 10 degree. So before surgery, baseline visual field must be done.
Okay, sir. Thank you, sir.
You must ask questions.
So I think Dr. Reddy has given very exhaustive talk. I think there is so well with all the examples. I think PGs should go through this talk 2-3 times, and maybe then they'll be able to fully digest, and then they should email Dr. Reddy the questions, because it is very exhaustive talk with all aspects covered with case studies and all. So that is very rare to have in depth so much information regarding visual fields.
As long as you hear, while hearing, you feel that you understood. But again, you go on seeing the visual fields, you should go on interpreting.
Yes.
You follow the systematic, the patient data, test data, reliability data, the raw data, grayscale, total deviation numerical plot, pattern, total deviation probability plot, pattern plots, glaucoma global indices, glaucoma mean deviation, localized scotoma, generalized scotoma. What is the 7th best deviation point? You have to do lot of exercise, Any then
Vangi, if then there are no questions, maybe you ask the PGs to go through this, and I can understand maybe in one go they may not be able to understand. Both the sessions they should go through, and they can email me or Dr. Reddy the questions, especially Dr. Reddy regarding any aspect. And all of you must go through his book, because all this is given in a very nice factual manner with case studies. So that will help you for future, to understand visual fields.
Okay, sure, sir.
So you are wishing everybody happy Diwali.
Yeah, very happy Diwali in advance to everyone. Yes. And also I'd like to thank you, the Enthode Pharmaceuticals, for their logistic support for organizing this webinar for us. Yeah. Thank you, Reddy sir. Thank you, Tanuj sir.
Thank you, Dr. Shubhangi. You did very well, and thanks to all Sstc and Dr. Deepa for organizing this, and Dr. Reddy for exceptional talk.
But we are very happy, sir. You are there.
Thank you.
Okay. Thank you, everyone.
Thank you.
Thank you, Deepak, and thank you, Mathur, for inviting me to talk to the PGs on this platform.